He is doing training with Pan-African Academy of Christian Surgeons in collaboration with COSEXA, which is the College of Surgeons, East, Central, and Southern Africa. As we all know that fluid and electrolytes is a core component of a surgical training. It is well-written chapter in many surgical books, including Schwartz's textbook of surgery, which is the main reference book in many of the training facilities. Dr. Minja has volunteered, and we want to thank him for his kind heart. Would you please start the presentation? You have 45 minutes to go through what you have prepared, and then we'll open the discussion for questions, answers, additions, subtractions. The floor is yours, Dr. Ari. You're welcome. All of us, we should remain muted throughout. If you throughout his presentation, have and comments and the troubles, jot them down. Mr. Administrator, kindly take care of all those who has open microphone so that we can have an ambient environment for us to learn. You're welcome.
Thank you, and it's an honor to present in this webinar. And in person, I would like to I'm very happy to present being, I can say, supervised by you because you've been in PACS, and it's a real good opportunity here. So the opening of fluid electrolytes of today, we're going to do have introduction. We're going to discuss fluid physiology, electrolyte management, perioperative care, and we are going to see some key special scenarios about fluid and electrolytes. And as we all know that surgeons are the masters of fluids, and because they must be, because we usually take care of patients who cannot drink. Sometimes patients are hemorrhaged, some patients who have undergone surgery, some patients who have lost fluid from the tubes, and some of the patients who also have drains which drain fluids from the body. And if we are doing that, then we have to really know very well how to manage fluid and electrolytes in our surgical patients. We all know that human body is a dynamic constant, and attention is needed to titration of fluid loss when therapy is a matter of concern here. So after said, so fluid status is a challenging thing to do, and to even start to embark on this act. Number one, because at one point in time, you really have to know what is actually needed from your patient and how you can help them. So we're going to start with the fluid distribution and dynamics. And from this part, let us start talking about total body water. Now, about total body water, we all know that when you are a fetus inside the mother's womb, usually have a lot of fluid. Like before birth, usually have more than 90% of total body fluids. But as you are growing in utero, you are going to have your fluid decreasing with time. And when you reach a term, you are about 80% of the total body. Your total body water is about 80%. And then you will proceed. And if you are a girl, you will acquire some fat. And with just some fat, you're going to have relatively a small amount of fluid compared to men. And the extracellular and intracellular fluid dynamics usually change, but the extracellular part is the most part which usually changes a lot. And so starting with a 70 kg adult man, so this man, you really have to fluid, knowing that 60% will be total body water. And then if there is a woman, then it's about 50%. And then as you proceed on, you really know that 2/3 of that will be intracellular and 1/3 will be the extracellular fluid. And then of the extracellular fluid, 3/4 will be the interstitial, which is about 10 liters, and plasma will be 1/4. So a little bit of this definition of terms before we proceed. When you hear the word osmolarity, is the actual number of osmotically active particles which are available in solution. For example, taking sodium chloride. When sodium chloride is dissolved in water, it breaks into sodium ion and chloride ion. And then 1 millimole of sodium chloride will give you 2 millosmoles if you break it down. Now, it's because now you have a chloride and sodium which have osmotic and the serum osmolarity is calculated by the formula I have provided here, which you take 2 multiplied by the sodium concentration, glucose divided 18 over 18, and then beyond divided by 2.8. And the normal range is about 290 to 310. So when you hear the word equivalent, equivalent means the chemical combining activity, and its formula is atomic weight divided by valence. And so if you are talking about now, it is a chemical combining activity of one element, which means if you have one sodium, we have a 1 mil equivalent, it's equivalent now to 1 millimole. And if you have a magnesium, because it's combining with the power of 2, then you have 2 millimole. Now you have osmolality, which is a total number of solute per kg, and unit is a osmol per liter. Now, talking about the fluid compartment, this is a very, very important part, and understanding of the fluids almost starts everything starts here. Now, you can see we have plasma, interstitial fluid, and intracellular fluid. Now, you have barriers. In other words, all of them are permeable, are freely permeable to water. And then we have osmotic equilibration, which occurs when water moves across the membranes from areas of lower to the areas of higher osmolality. So electrolytes exchange is free between interstitial space and also the plasma. Now we have another barrier, which is from the intracellular space to the interstitial space and plasma. This is different because it has plasma, interstitial fluid and plasma with higher sodium concentration, and then intracellular space has a low sodium concentration. There is a steep gradient here, which is maintained by sodium ATPase pump, which pumps out sodium and pumps in calcium inside the cells. So taking into consideration what we have talked about, if you give a patient normal saline, which has about a concentration which is nearly that of the plasma and interstitium, it will traverse to the plasma and then it will enter in the interstitial fluid, but it cannot now go to the intracellular fluid. However, if you give the patient D10, it has a low osmolarity, so it can go across all the compartments and all the way to the intracellular fluid. If you give the patient albumin, we all know that albumin has a higher molecular weight, which cannot cross the endothelium, so it loves to stay inside here. The same will apply to dextran and also the heta starch. So understanding this is very, very important before we embark on fluids. We all know we have a lot of fluids. Common one is a normal saline, which we usually use most of the time as a surgeons, and it has a sodium of 154, chloride 154, and then it has no bicarb, no potassium, and also no calcium. Osmolality is 380. So they can vary from isotonic, hypertonic to hypotonic, with isotonic having 250 to 375, and then hypertonic is about 375, and hypotonic is less than 250. So that is how you can classify this saline. And you can also have half normal saline, which is 0.9, like divided by 2. So it is half sodium of 77, chloride 77, and then you have osmolality is 154. Moving further, we have 0.2 NES, and then it is a division now of, like you've divided by 2 again. You have a sodium of 34, sorry, 34, and then you get osmolality is 68. So this is like you have taken a quarter of a saline. It's like a 1/4 of something here. And when we proceed further, we don't have anything lower than that rather than D5W, which does not have any sodium, does not have any chloride or potassium, but it has a 5 gram of dextrose per deciliter, which usually accounts for this 275 osmolarity. And that is why that concentration it is used. There is a misconception that ordinary intravenous fluid administration is feeding by vein, but that is not true. We will explain a bit the disconnected between D5W and the 170 kilocalories, which is obtained when this is dissolved in water, because it usually breaks down and gives you energy. And then we have D5.45, which is used in most of our NICUs, and then we have the Ringer's lactate. Now, talking about the Ringer's lactate, it is also known as Hartmann-Darrow's. It is also a Hartmann-Darrow's or attempt at creating the fluid, which is roughly equal to extracellular fluid. Yeah, like you can see, this wants to mimic the normal extracellular fluid by trying to substitute all the relevant components which are available here. And some of the concentration of ions like calcium are not like in the normal range. They've already attempted to add a lactate there, which is good because lactate is a 3 carbon molecule. It is broken down into 2 carbon pyruvate and 1 carbon. And then this carbon can dissolve in water and it can give you bicarbonate. This is very important as a buffer in metabolic acidosis. Now, dextrose in water is like 5 grams of dextrose, and you have put it in like a deciliter of water. And we have, this is a compound which is the intravenous form of dextrose, and it has a 3.4 kilocalories per gram. And we can have a 5 milligram per deciliter. We will multiply it by 3.4, multiply by 10, then you can get like 170 kilocalories for every liter of this solution when it's used, and it can generate energy. So if you take that to a mathematical equation to calculate those kilocalories, they can give you about 4,185 joules. Now, an interesting part about the hypotonic fluids is that why we don't really use them is because this can go directly to the intracellular space, and then this can give you some troubles, which may include like cell lysis and so forth. Hypotonic fluids causes fluid shift and can result in releases of the red blood cells, like in this situation here. We have some alternative resuscitative fluids which are available in the market. Some of us maybe see more than one, but I have seen one, which is albumin. These are the fluids. colloids are better at filling the intravascular space than the crystalloid. Filling itself with colloid is good. But further, in some cases, fluid from the interstitial space is drawn into the intravascular space by oncotic pressure generated by the colloids. So like 1 liter of 5% albumin, it can draw about 0.5 to 1 liter of fluid in plasma, and 25% can do like about 4.5 liters. And then this can sometimes be a very good because it can preserve renal perfusion in states where you have decreased the renal, you have problems there. And problems with colloids is that they have a very high oncotic pressure and they can lead to capillary leak, and then which can leak into the interstitial space. And this must sometimes worsen edema. So you will expect that if you wanted an ideal fluid, it is when given directly to the intravascular space, it will stay completely into that space and there will not be leaking into the interstitial space. And it will not cause complications, but there is no such fluid. And why people don't like colloids is because we are looking on health patients who do not need um, we are looking on the sick patients, and then we don't have these complications. But some of the patients might benefit from them, especially when we are doing a replacement to them, like patients with chronic liver disease. There was a debate about this thing of crystalloid versus the colloid, and then this was resolved by this safe study. And in this study, is that there was it was a saline versus albumin fluid for resuscitation, and it was done in Australia and in New Zealand in the Intensive Care Society in 2004. And it was a multi-center, double-blind, randomized controlled trial with nearly 7,000 patients. And the method was randomly assigned like saline, and then about 3,500 patients were assigned albumin, and the primary outcomes were 28 days mortality. The findings were interesting. About 726 patients died in the albumin group, and about 729 deaths occurred in the saline groups. There was no difference in new or multiple onset organ failure. There was also no difference in the ICU stay or hospital stay. So conclusion from this trial is that the crystalloid remained the sustain fluid of choice in critically ill patient and also most of other patients. Let's go to the electrolyte management, and this is also the important part here. And in this electrolyte management, we begin with fluid disturbances. In what ways fluid can be disturbed? Number one, you have disturbance in deficit, and you can have a lot here from the GI losses from NGT, vomiting, diarrhea, third spacing of fluids like in burn and sepsis, patients who have undergone long operations, patients who have fever or sweating, patients with blood or plasma losses, especially trauma or surgery. And also you can have like a patient who are dehydrated. You also have disorders of fluid excess with also a number of causes. Now, the first disorder here is hyponatremia, and hyponatremia is the most common, and it can occur from a number of causes here. You can have like a patient with intestinal fistulas like a biliary, duodenal, gastric, or pancreas. And you can have patients with a gastric outlet obstruction with severe vomiting, who have patients with a renal tube aspiration, and SIDH, which is a syndrome of inappropriate antidiuretic secretion. Also, you can have patients who have immediately after surgery in trauma, who have increased ADH and usually have sodium depletion. So in discussing this area here, it is very important to know the volume status of the patient, like it is high, normal, or low. That is a very important part in managing this patient. And then you have to classify them according to severity. Is it mild, moderate, or severe? And you have to know the duration if it is more than 2 days or it is less than 2 days. And of important here is that it generally some combination of fluid restriction and some administration and diuretics depend on the volume status of the patient is done. But the treatment starts when the sodium level is less than 120 milliequivalent per liter, plus or minus symptoms. So if the patient are hypovolemic, then if the patient are hypovolemic, ask yourself if they are asymptomatic. If they are symptomatic, then isotonic saline can be used. And then if they are more severe symptomatic, you can go to hypertonic saline. If they are hypervolemic, then you can restrict water, give salt, and if they are symptomatic, then you can go to hypertonic saline and loop diuretics. If they are eulemic, then do free water restriction plus or minus saline. But if they are symptomatic, then go to the hypertonic saline. Now, based on the state which these patients are, they can be acute or in a chronic phase. In acute phase, we can go to 0.9 NES or 3% sodium chloride, depending on the volume status. But you will have to know the rate, like it's 1 to 2 milliequivalent per liter per hour for asymptomatic, and 4 to 6 milliequivalent per liter per hour for symptomatic. The maximum correction per day should not exceed 10 to avoid this osmotic demyelination syndrome or pontine myelinosis. And for chronic, we can go to NS 1 milliequivalent per liter per hour, but the maximum is 4 to 8 milliequivalent per liter per day. If the patient are acute and symptomatic, they are usually in emergency, so we usually go straight into the 3% hypertonic saline, which has about 513 milliequivalent per liter. After addressing these problems, then you have to treat cause, because you will go to the cycle of correcting, then a problem recur. So most of these things we usually don't do. I'm also guilty of these things, but it is better to know the better way and maybe aim now to do better. Number one, you want to correct the patient low sodium levels. Know the total body water, and then know the correction factor. So for adult male, we've said it is 0.6, and the adult female is 0.5. Now, you ask yourself, what amount of serum sodium this patient need? And then add that to 1 liter of the infusate which you are going to give. So calculate the change in sodium, like take infused sodium and then minus serum sodium, and then on bracket divided by total body water plus 1. This question is available. And then you know the strength of what fluid you are going to use in the infusate. Like what fluid are you going to give this patient? Are you correcting with hypertonic saline or normal saline or what? And then number 3 is that calculated the rate of infusion limited to the allowed rate which you are going to correct. So no, there are a lot of things which are going here, but bear with me, we will go to the some of the worked examples. We have 45-year-old male, body weight 70 kg, sodium is 120, and has acute symptomatic hyponatremia. First step, we have to know his total body water. Again, we have seen it is 42 liters. Number 2, you ask yourself, 1 liter of 3% sodium chloride will change serum sodium like by what? So you take the infused sodium which you are going to give, you minus serum sodium, which is the patient calculated, you add the total body water plus 1. So you will end up with the equation like this, and then you are going to have about 9.13 milliequivalent per liter. And then you ask yourself, in acute symptomatic hyponatremia, the typical goal is to raise the sodium by 1 to 2 milliequivalent per liter per hour for the first few hours until symptoms improve. And then we ensure that we do not exceed 8 to 10 milliequivalent per liter in 24 hours. So since if I give this patient like 1,000 mils will raise the sodium by 9.14, we can calculate the volume needed to raise a 1 milliequivalent per liter. So you'll end up with a 109 mils per hour until symptoms resolve. So you cannot give this patient like 109, you can opt to give 1,000 mils for the 24 hours. Going to hypernatremia. Hypernatremia, we see it rarely because most of the patients here, if they have intact thirst mechanism, they can drink some water and they can have their symptoms relieved. But it also has a lot of causes. We have iatrogenic sodium administration, we have mineralocorticoid excess, we have aldosteronism, Cushing, and all fours. And also we have patients with disturbed volume status, in terms of like a normal and low, but in constellation with all these causes here, the most common cause are renal dysfunction and cardiac failure and cardiac and drug-induced, like in cases of patients who are taken NSAIDs. Now, this can also be classified according to um, um, severity, like in mild, moderate, and severe. So in mild case, like sodium level 146 to 150, moderate level is 151 to 159, and severe it's more than 160. And then we classify it according to duration, less than 2 days or more than 2 days. Now, the important part about hypernatremia is we all know that this patient is water deficient. So if this patient is water deficient, we are going to restrict saline and the sodium because now the volume is high. And then if they are hypovolemic, you can correct the volume deficit. And then the correction has to be gradual, initial infusion of normal saline, and then you can do the infusion of half saline like 0.45, and then later we can end up with a 5% dextrose. And you have to titrate in order to achieve a goal. In acute symptomatic hypernatremia, the goal is about 1 milliequivalent per hour and 12 milliequivalent per day. And in chronic is 0.7 milliequivalent per hour. Let's take the 70-year-old male who's 70 kg and he has a sodium of 165, and we are going to use like D5W to correct this. Remember that this patient, if he's also using sodium from urine, you also have to correct the urine losses. Sorry, fluid loss from the urine. So you have to know the total body water of this patient. So you take 0.6 divided and multiply by body weight, you get about 42 liters. So you have to know that you have to know the differences in the sodium of the patient and also the type of the fluid you are going to give. So if I'm going to use the total body water, it means that the patient like levels is 165, and the total and I'm going to use like a D5 like W to correct it. It has sodium for 0, so I put it there, and then the patient has total body water of 42, and then I'm going to add +1, and I'm going to get 3.88 millimole per liter. So that is the water deficit in this patient reflected in the amount of the sodium, which is so this is like it's amount of the sodium and water deficit that is required to be corrected. So you are going to establish the goal of correction, which is 10 millimole per liter per day. So you take 10, you divide by 3.88, you get like 2.6, and then you add the urine losses, which is 2.6 plus 1, and you get the 3.6 liters. So which rate is going to be there for the correction? You take 3.6 divided by 24, you get about 150 mils per hour. Now, quickly, let's go to hyperkalemia. Hyperkalemia is also among of the disorders of the fluid balance, and most of the causes will be from the increased intake of potassium supplementation, giving the patient blood, hemolysis and rhabdomyolysis, like from the trauma patients, and also patients who have uh, uh, increased disease from the intracellular space, like patients who are acidotic, and also like rapid rise from the extracellular osmolarity. But we also have disorders from impaired excretion, like patient who is using potassium sparing diuretics and patients who have renal insufficiency or failure. So how are we going to treat symptomatic hyperkalemia? You can start with the Kayexalate. The Kayexalate is the one which are administered in the oral, like 15 to 30 gram in 50 to 100 mils of 20%. Then like we have also Sobito, which is rectal administration is 50 gram in 200 mils of 20% Sobito. And then we have dialysis for severe cases. You can shift potassium by giving one ampoule of D50 and regular insulin like 5 to 10 units IV. And then you can also give bicarbonate, one ampoule IV. To counteract cardiac effect, you can give calcium gluconate 5 to 10 mil of 10% solution. And in going to hypokalemia, most of this will occur from inadequate intake, like in dietary, or you give patient IV potassium IV fluids. Also, patients who are given TPN where excess potassium is not given. Also, in patients who have excessive potassium excretion, like a patient who have hyperaldosteronism, and also patient taking medications. Also, you can have GI losses like loss from potassium containing GI fluids like fistulas and diarrhea. We also have renal loss of potassium to conserve sodium in response to gastric uh, losses. So in this area, the aim of potassium is to correct it to the level of 4 milliequivalent per liter. So if the patient are asymptomatic and they are tolerating enteral nutrition, you can opt to give like KCl 40 milliequivalent per enteral access, like you can give it in one dose. And if the patient are asymptomatic and they are not tolerating enteral nutrition, you can give KCl 20 milliequivalent IV 2 hours, and you can give this in 2 doses. If the patient are symptomatic, then KCl 20 milliequivalent can be given hourly and 4 doses. Recheck potassium levels after every 2 hours at the end of infusion, because now you don't want to evaporate and go to hyperkalemia. And if it's like less than 3.5 and they're symptomatic, you can replace them as per the above protocols. Now let's go to the calcium. There is this complex diagram which shows the calcium metabolism, but the important part about calcium is that 1% is in the extracellular space, and the majority of it is in the bonds. It exists in three forms. It's bonded to albumin, and it is diffused between intracellular and the extracellular compartment, and it is also bonded to anions like in bicarbonate and also phosphate. And its ionized form is very important because it can help us in coagulation, muscle contraction, hormonal function, neuronal function, and also renal cellular function. Now, hypercalcemia is less commonly encountered in surgical patients. And primary causes are hyperparathyroidism. This is the cause of about 90% of cases of hypercalcemia. When you see this, suspect here, osteopenia, osteoporosis, and also renal stones. Hyperfunction of parathyroid adenoma through four-gland hyperplasia can also be a cause, and also bone metastasis with secretion of PTH commonly from breast is also a cause. Some patients may be taking medication like lithium or thiazide diuretics can also be a cause. And symptoms can range from nausea, abdominal pain, and also muscle pain and and weakness. But can also go to neurological symptoms, and some of them might have cardiac abnormalities, which may be detected by EKG changes. The management of this is very important because it's depend on the cause. If you have tumors, like do surgery for those tumors. If you have hyperparathyroidism, then do the surgery. If it is you have like to increase osteoclastic activities, give biphosphonates. Treatment is required when you have calcium more than 12 milligram per deciliters and is symptomatic. When symptoms are noted earlier, may rapidly progress to death, and treatment is usually by repeating the associated volume deficit, inducing a brisk diuresis with the normal saline. For the cases of hypocalcemia, its concern is when serum calcium is less than 0.8 like millimole per liter, and the cause is calcium loss, decreased intake, or increased release. And the specific causes in surgical patient are hypoparathyroidism, especially after head and neck surgery, also cancer resections, and it can also be a complication after total thyroidectomy. There is one important thing about hypocalcemia which has to be taken in mind is presence of acute illness and also hypoalbuminemia. Because albumin binds calcium, low albumin will cause low total calcium, but does not affect the ionized calcium. So if ionized calcium is not checked, then patients with low albumin, a corrected calcium level should be calculated using the formula. And there is a formula for calculating this in order to get the important true hypocalcemia. And so how do you do this? Is that if you have hypoalbuminemia, you take the normal albumin, you minus the patient's albumin, and then you multiply that by 0.8, then plus serum calcium. Calcium levels are in millimole per liter, and the albumin levels are in gram per liter. So if you have acute symptomatic, you should treat it with the 10% calcium gluconate to achieve a serum concentration of 7 to 9 milligram per deciliter. Associated deficit in magnesium, calcium, magnesium, potassium, and pH must also be corrected. So patient maybe have a gastric access in their tolerating enteroid nutrition. You can opt to give calcium carbonate, and you can check ionized calcium levels in 3 days. But patient without gastric access or not tolerating enteroid nutrition, you can give calcium gluconate 2 gram IV over 1 hour, and you can give just one shot, and then you check ionized calcium. Phosphorus is not that much encountered in disorder, but it is important information of ATP, and it mainly occupies intracellular space. And extracellular concentrations are controlled by the kidneys. Hypophosphatemia causes a decreased intake, increased excretion, and shift of phosphorus into the intracellular space. And treatment is for the patient who are tolerating enteroid nutrition, you can supplement it with phosphorus, and you are supposed to check phosphorus levels 4 hourly at the end of infusion. And hypophosphatemia is for this patient who have mostly like renal insufficiency who cannot excrete phosphorus, and also patient with renal failure and massive cellular disruption, because we all know that phosphorus is is next to potassium in concentration. How do you treat hyperphosphatemia? You bind it. You can give sucralfate, or you can give aluminum-containing antacids or calcium acetate, especially when hypocalcemia is present. If it is more severe, you can dialyze this patient. Going to magnesium. Magnesium, we know that it's a cofactor which involved in reactions involving ATP, and it regulates the activities of calcium as muscle contraction. It's similar in calcium Similar to calcium, the majority of magnesium is still intracellular and half is in the bone. But when it exists outside, it is existing in three forms. It can be bonded to protein, an ion bond, or it can be in ionized form. Only fluctuations in tissue levels usually causes these symptoms. A difficulty to associate symptoms with plasma levels and magnesium should be replaced until plasma levels are above the upper limit. Hypomagnesemia is rare. Probably most of us will not encounter this in most of the patients, but it's usually common in surgical patients and critically ill patients, and we don't have a routine of testing it. The causes are increased intake, alcoholism, IV fluids, and TPN without adequate supplementation, increased excretion, and also loss, especially patients who are using alcohol or diuretics. The good thing about hypomagnesemia is that the symptoms are identical to those of hypocalcemia, and magnesium should be replaced both because of its correction on the cellular activity and metabolism, as well as the fact that it can cause hypocalcemia and also hypokalemia, which can be difficult to correct. You have magnesium disorders, correct magnesium first, then you correct hypocalcemia and also hypokalemia. Hypermagnesemia is unusual and is unusual, but it can develop severe symptoms, which may include loss of deep tendon reflexes, ileus, urinary retention, paralysis, and apnea. And in severe cases, it can cause bradycardia, hypotension, and also heart failure. And excessive intake in the setting of renal insufficiency or failure may also be a case here. High level of magnesium are usually fairly well tolerated. But if you are going to correct, then you have to create a recipe which has a 5% dextrose, 0.45 NES with 20 milliequivalent of KCl. And in children, you can go to dextrose 5% plus 0.2 NES, then you can add 20 milliequivalent of KCl. Now we have talked about all these fluids and electrolytes abnormalities and all of these points. At one point in time, we have a clinical question to ask ourselves, are we resuscitating very well our patients or not? And everybody is looking for a theoretical endpoint of resuscitation, which is a point below which stroke volume and cardiac output and the organ perfusion can be increased by administration of a fluid. And above which, if you give maybe a fluid, will lead to consequences of fluid overload. And the MAP has been used over time, but it has been inconsistent and correlates resuscitation often leading to overload. And central venous pressure has been used. It's usually indicative of fluid overload or cardiac failure affected by intrathoracic pressure. Sometimes it's affected by the intrathoracic pressure, and you cannot maybe rely much to it.
Thank you.
Urinary excellent. Some of them have been advocating it. Have also talked about serum lactate and base deficit. But in most of the literatures, the hemodynamic endpoints like MAP and CVP are still in question. Urinary output has been demonstrated to be good, and also the other literature support you as a doctor making a very good follow-up of the overall trends of the patient's vitals and everything, rather than relying on one central point. The disorders of acid-base balance are also common in our surgical patients here. And the metabolic acidosis is the common one, and it is caused by increased acid intake. For example, like HCl, ammonium ions, toxins, like ethylene glycol or methanol or cyclates. But also you can have disorders which generate a lot of acid, like ketoacidosis, lactic acidosis, renal insufficiency, and so forth. But you can have loss of bicarbonate, which is now the area where we come to have surgical patients with diarrhea, fistula who have undergone ureterostomy, renotubular acidosis patient, and the patients who are using the acetazolamide. The body compensatory mechanisms here are very important. So we have our internal buffering system, which included the extracellular bicarbonate, and also we can have intracellular buffers where our bones and muscles are playing a very key important part. We also have a respiratory compensation, which is hyperventilation, the small respiration which is usually like your body is trying to prevent not to go too much acidosis. As well, you can have renal compensation where it can lose a lot of protons like hydrogen, ion, ammonium, and also it can increase bicarbonate reabsorption and also generation, which can be a very good buffering system. We have types of metabolic acidosis where you can have high anion gap acidosis, where you can have like you taking a lot of exogenous acids like methanol and salicylates. But also these acids can be produced from inside your body. For example, patients who have starved or the patient who are taking alcohol or diabetes, as well as lactate, which is coming from the shock and hypoxia, releasing a lot of acids, then releasing ion gap. Also, you have renal failure, where you have organic acids building up. And so the clinical pill to take from this patient is that lactic acidosis in surgical patients is most of it is due to hypoperfusion and shock. And treatment is to restore perfusion and then to do volume resuscitation and then not to aim that much on bicarbonate. Like some of the areas they usually rush to bicarbonate when they are not severe metabolic acidosis. And giving bicarbonate usually increases your carbon dioxide, which goes and mixes with water, and then it worsens the intracellular acidosis. Especially, it's dangerous when you have patients who have acute respiratory distress syndrome because now they will hyperventilate a lot. Now you can have normal anion gap, like it's hyperchloremic acidosis, and the causes can be GI losses like GI bicarbonate loss like in diarrhea and fistulas, or renal bicarbonate loss like renotubular acidosis, or patient taking acetazolamide. And also you can have exogenous acids like HCl and also ammonium. The mechanism is that you lose bicarbonate, and then bicarbonate is going to be balanced by increased chloride, and then you are going to have an anion gap, which is going to be unchanged. So you lose bicarb, you absorb chloride, then an anion gap stays the same. Diagnostic clues to measure urinary ammonium, which we do in most of the centers here. But when you have low ammonium excretion, then that might be the indicate that this patient is having a renal tubular acidosis. Metabolic alkalosis is not that much common, but the key, like the important message to take is that the pathophysiology requires two conditions. Either you have bicarbonate generation, which is increased, or you have impaired renal excretion of bicarbonate. And the mechanisms are loss of fixed acids like gastric HCl, or you have a gain in bicarbonate, and then this can be worsened by potassium like depletion. And then these are the causes which are available from the book of Schwartz. You can go and review them slowly one after one if you want to really learn about causes of the metabolic alkalosis. And so sorry, this is slide I think they've been missed, but this is management of patient who had metabolic alkalosis with paradoxical aciduria from gastric outlet obstruction. This is also a common cause of metabolic alkalosis. And adult, maybe they can be due to duodenal ulcer disease, but the mechanism of this is also well explained. But for the sake of time, I think I'm not going to go through this. Let's go to pre-operative care. And just touch a little bit about the key important areas here. Basically, this year for the NPO patients, like you've made somebody not to drink something, then you need to maintain their state of euvolemia. So you replaced it in according to the patient's body weight. And then, like this has been studied, for example, in children, for the first like 0 to 10, you can give 100 ml per kg per day. In 10 to 20, you can give additional 50 milligram per day. From weight more than 20, you can give additional 20 ml per kg per day. And alternatively, you can calculate the losses which are going on, like in urine and stool and insensible, and you can replace those. But when you do this method, you have to use like D5, 4.5 NS plus 20 milliequivalent of KCl per day. The important thing is that if you have patients who have fluid issues here, replace the deficits if they are there, then replace the GI losses. And if we have no like patients who have third space losses and you consider them, you are not likely to go and be more precise because these are just estimations. But to have an idea like the patient is having a third space loss, like GI obstruction, peritoneal inflammation, patient with ascites, burns, severe soft tissue infection, necrotic fasciitis is very important in order for you now to know how much am I going to give in my patients. Important thing again, consider the fluid status of your patient. And intraoperative fluids. Induction of anesthesia itself leads to loss of compensatory mechanisms. And hypotension can occur if volume deficit is not corrected before the patient undergoes surgery. So intraoperative hemodynamics by therapy, pre-op. So this is the job we should have done before the patient is on the table. But also hypotension can occur if fluid deficit is not corrected before surgery. And also we have intraoperative hemodynamic status is stabilized by you adequate maintenance fluid therapy pre-op. You correct the known fluid losses and replace the ongoing losses. For example, in abdominal surgery, you also add the extracellular fluid losses which usually occur, and this is usually done like giving patient 0.5 to 1 liter of balanced salt solution. Why you are giving this in intra-abdominal surgery is because the patient like can have bowel edema. Some patients can have a loss of peritoneal fluid. They can have a wound edema during surgery, and also the patient can have large soft tissue wounds, which may require this replacement. Now, the important part in post-op fluid is you assess the daily assessment of before, like what this patient need, and then you use those information to correct the fluid. The important consideration is that current estimates of volume status are important, and then you have to project the ongoing fluid losses, and then you have to account for pre-op, intra-op losses which occur, which have not been replaced, and also replace the ongoing requirements, and also the maintenance fluids have to be all given. The water needs in pediatrics, I think I'm not going to go through this because I've already given you the formula in the past slide. This is an example of the example of a child water replacement. Like the first 10, it's 4 to 1 for the first 10, second 10, and then the extra weight. The extra weight after that is replaced by 1 meal per kilogram per hour. So Let's talk about the enhanced recovery protocols here.
You,
We know we
Dr.
had
Minja, 15 minutes, eh?
okay, okay, it's just I'm winding up. So, Henrik Kellet, a Danish surgeon, designed a RAS protocols which were designed to optimize preoperative management across surgical specialties. And this included like multimodal strategies which maximize preoperative organ function, reduce complication, and then shorten hospital stay to improve satisfaction and also lower the patient costs. So, like in European Society of Anesthesiology Guidelines, which also adapted the RAS protocols, promote like allow clear fluids for up to 2 hours in patient pre-op, which is a shift from the traditional fasting. And also you have to encourage carbohydrate and electrolyte-rich drinks to improve hydration and metabolic response. And also intraoperative and postoperative focus is that you restrict sodium in the IV fluids to avoid fluid overload, and also avoid avoid the overload linked to prolonged ileus and coagulation abnormalities. And then you have to have you can have a lot of approaches here based on your goals, like you have to be goal directed, tailor fluid according to patient need, and also as has been shown to reduce post-op morbidity and length of stay, independent of the ARS measures which have been used. Let's go to specific scenarios as I'm winding up. In trauma, the source of fluid is crystalloid and preferably ringers lactate because not much of NS is being advocated because of a kidney injury, and colloids are not that much advocated in this area here. You should know you have to have the idea of a permissive hypotension, which has been advocated here, because too much fluid is going to induce coagulation problems and also pulmonary edema to your patients. In patients like hemorrhage, you should sustain fluid volume and aim for 80 to 90 millimeters of mercury until like bleeding is being controlled. Some areas you can have like specific injury requirements, like if you have penetrating trauma and they are bleeding, use like permissive hypotension until surgical control is obtained. Patient with blunt trauma with the head injury, then avoid hypotension and maintain CPP. If the patient have chest trauma, be cautious of fluid to avoid worsening the pulmonary edema. Lastly, in patient with sepsis and septic shock, initial resuscitation is LF fluids are critical to restore perfusion. And according to Surviving Sepsis Campaign, it's a 30 ml per kg of IV crystalloid for the first 3 hours for patients with hypotension or lactate more than 4 millimole per liter. Preferred fluid is balanced crystalloid like Ringer's lactate and plasmalite, but this one we don't have it here. And you have large volume of NS, you should avoid them because they can lead to hyperchloremic acidosis. Are there the risks of over-resuscitating your patient? Yes, they are. And much of this worsening of edema and also inducing ARDS. In patients with sepsis, know when to transit to vasopressors. Like if hypotension persists after fluids, then starting norepinephrine early. And the fluids plus vasopressors together often are required to stabilize the patient's perfusion. Are you going to give the fluid boluses to pediatrics, or which we also learned this has been discouraged, and then we have this paper which was published in New England Journal of Medicine, which I was talking about mortality after fluid boluses in African children with severe infection. This was a multi-center study. And briefly in this study is that they were looking at children who were given boluses of NES and also boluses of 5% albumin solution compared to the children with the maintenance fluid only. And then they concluded that fluid boluses significantly increased like 48-hour mortality in critically ill children with impaired perfusion in these resource limited settings in Africa. We have a confounder though that they given albumin in also these groups. Lastly, it's burns. You all know this is usually done by the Parkland formula, and its difference in resuscitation is that the fluid type is crystalloid in the syringalactate, which is fluid of choice in resuscitation. Colloids or albumin can be sometimes be considered after for 24 hours to reduce edema, but evidence is mixed. Some patients have been benefiting, but others not. But you should avoid NES, which can worsen hyperchloremic acidosis. In pediatrics, not that much is different, but in neonate and infants, they have a higher glucose needs and immature kidneys. Therefore, you have to do the careful titration of your fluids. And then in major surgery and trauma, they have a lot of greater space losses. Therefore, you need to replace a lot in this area. I think we can begin the next part. Thank you.
Yeah, thank you very much. I appreciate for the effort that you put to make these slides together and to make this content valid and presenting with the resilience. You never fed up, the voice remained the same. All these are qualities that you put to make this presentation a success. And I'm very happy that you have also noted and deliberately described throughout your presentation that fluid electrolytes are the cornerstone of your acute management of whatever patient you are treating, whether it's trauma, whether it's septic, whether it's pre-op, whether it's immediate postoperative. And it is important that we discuss all weather, all time, and get ready to use this knowledge to perfect your management of your patients. Now the floor is open. We will accept comments and questions and explanations from surgical trainees first, and then I think we'll use 15 minutes, and then we'll have 5 minutes remarks that will be given by Dr. Vihar Kotecha, and 10 minutes that will be given by Professor Mchembe, and that will mark probably the end of our discussions and open to the next phase of this talk. So those who have questions, you can raise up your hand, or you can unmute yourself, or you can write in the chat box. The floor is open. Welcome, welcome, welcome. Godfrey, you have something you want to say? Baraka, I can see some microphones are still on. I do not know if they want to make a comment. Msemo, Boniface. Melissa, Anwar, Clement, Emma, Henry, Isaac, Kaguo, Rasto. Yeah, anybody. I'm going to read some of the things that you have mentioned in the chat box. On the part of electrolytes, this is from Haiten Solanki, is asking that on the part of electrolyte, chloride was not covered. Does it mean it is because of less importance physiologically? Yes, Dr. John. Minja?
It's interesting, but I've not seen it even in the textbooks talking about the chloride abnormalities. But because of its, I can say majorly because of it, the dynamics of it usually goes together with sodium. Like within your body, whenever we have like all areas where like sodium can be lost, um, there is like something related to chloride being like together. So most of it maybe if you have disorders related to the to sodium, most of it will, I can say maybe they will be corrected with uh, sodium chloride, again with corrected chloride. But to see or say that they have disorders of chloride alone or in isolated, I have not seen. I can say most of the interventions and the pathological processes are linked with sodium. This is my guess, but if there is anyone in my audience who can have a better explanation, I think it will be much better.
Oh, don't worry. We have so much. The second question is about when you have severe hyponatremia and severe hypokalemia, can we correct all of them simultaneously?
Most of it will have to start with hyponatremia first.
Okay. So you are discouraging simultaneous correction.
Yeah, because most of after you have collected most of the electrolytes like related to potassium correction, after you have done like your sodium correction very well, then you check your potassium. You can now see the clear picture, and then you go to corrective hypokalemia. But this is just a thought. Maybe someone may have another opinion about it.
Okay. Yeah, thank you very much. That was from John Jackson, and we have Dr. Isaac Patrick saying, I think the presentation was well informed. Thanks a lot for your presentation. Is there any role of calcium gluconate in hypermagnesemia?
Okay, calcium.
Gluconate in hypermagnesemia.
No, that one I cannot answer.
Okay, and then we are welcoming other commentaries from other participants. The chat box is open. You can unmute yourself and make a comment, ask. So what are the commonest fluid and electrolyte challenges we see in patients who is undergoing, let's say, TURP or open prostatectomy? You know, we tend to irrigate, they tend to lose a lot. Do you have any specific commentary on that? Another comment is from Erasto Ipiana. Thank you very much, dear presenter, for a very well elaborated presentation. I would like to know, after how long should I control for electrolytes following correction?
Okay. Most of the advocates of most of the readings from the international guidelines and everything, they recommend like an hourly checking for electrolytes, especially when we're dealing with the sodium. Like it's an hourly thing which you usually do. For the potassium and the other disorders in acute corrections, they also do them hourly. And I've seen it at the LMC. It is very difficult if you don't have like a point of care tests to do this. So I will also leave it to more experienced people among us who can go and tell the experience from their centers. At ALMC in ICU, we have a Chem8 machine which can give us where we can perform the multiple rapid tests. Even hourly, you can get the results. But once those machines are not working, you really have to take fluid. You have to take the blood to the lab, which takes a lot of time.
Yes, when to give sodium bicarbonate in patient with metabolic acidosis, like patient post-trauma or post-major surgery, abdominal surgery. What's your comment?
I saw this in one of textbooks is that it when they had in the severe low pH, which was going to impair the metabolic functions of a patient. I don't remember very well about the number, but it was around 7. It was 7.1, 7.3. I don't remember very well, but it's when like severe, you have a very low pH. And then you've done like corrections, you have restarted the patient with the fluids, and like the acidosis is still persistent. Yes, you can give the bicarb.
Yeah, thank you very much for your comment. I understand there is a colleague who wants this topic to be separated because he or she feels it is very, very difficult to cover. He used the word impossible to cover both acid and base disorders and electrolytes together with the fluids in one presentation. Yeah,
Yeah,
I understand.
I think Dr. Mugisha, it is true. Especially when we were going through the part of work, the examples, and then everything. But because we are starting these presentations and also preparations, everything, maybe we have a room to improve in a lot of things to come.
Yeah, but nothing is impossible. The patient is the same, and you need to fix him or her using the knowledge that you have gathered here today and the knowledge that will continue gathering over time. So nothing is impossible. Everything is possible. You just need to adjust and look at the things that you think are important for these particular presentations. Yeah, you never shy from a goal that have been given to fulfill, and therefore I thank you very much for preparing both. Well, Chucky is saying nice and well elaborated topic. I didn't hear much about the role of ECG changes seen in electrolyte imbalance patients.
Okay. We can start with the hyperkalemia. And so much of the ECG changes in hyperkalemia will present with the peak T waves. And also you can have other measurements disorders. And this can be from so they can have a peak T wave. You can have in severe cases, they can present with a sine wave like abnormality. And then this all, I can say this range from the values like if it is like 6, they have tall T wave. It's like more than 7.5, like they have a long PRI interval, wide QRS duration, and tall T wave. Sometimes it can reach 9, and then it can have absent P wave or a sinusoidal wave. So this is also not typical for all patients with the hyperkalemia because some of them may have, I've seen patients in dialysis who have sodium levels, of who have potassium levels of 6. But again, when you see the ECG changes, there are not that much findings which are corresponding to those levels. But that is the most common in hyperkalemia. In hypokalemia, you are going to have a prominent U wave, and also you are going to have a QT interval, which is prolonged. And sometimes patients with the hypocalcemia, even though we don't do testing of this patient, is like they're going to have also QT prolongation. And the other that was hypocalcemia, but in hypercalcemia, they're going to have shortening of the ST segment. That is as much as I can remember.
Yeah, thank you. Yeah, the last commentary that I would ask you to make before I welcome Dr. Vihar Kotecha to give his submissions is from Dr. Laxford Paul, who says, is it possible to a patient to be fluid overloaded and intravascular dry at the same time? If possible, how to handle that situation?
Oh, can you come again?
This patient has got a fluid overload and they have intravascular, they are intravascular dry.
Yes, I think
Can it happen at the same time? And how do you handle it when you want to do this?
Listen.
Yeah, we have some intruders here who are not yet.
Gonna have taken time, but it's okay. I'm gonna.
The admin take care of them.
Yeah, this is how you. Don't hold your nail holder like that.
Okay, go ahead.
Yes, it is possible. And when you have excess total body water, and then you find yourself you have depleted intravascular space. This was the third spacing which we talked about in two areas in my presentation. But the key mechanism here is that you can have a third spacing, and then you have a patient like their capillaries have inflamed, especially in sepsis and patients who have a pancreatitis, and who also have a low albumin causes, and then blood is moving from the from blood, and then it is moving to the fluid is moving from blood, and then it is going to the interstitial area. You can also have conditions like sepsis, liver failure, severe malnutrition sometimes. We have also seen this in patients with heart failure. I think these are the ones I've seen in my practice where patient is fluid overloaded, but he has a lot of fluid in the body, a lot of third spacing, but the amount of fluid participating in effective circulation is very small. So all causes of third spacing can be can cause that. But it was surgeons, I think, is when we fail to take care of the patient's edema, fail we to recognize the patient who are septic and who are more likely to increase like capillary leak, failing to monitor. And the most commonly of these patients are patients I think who have undergone laparotomy, who are fluid overresuscitated, but nobody is monitoring their output. Patients like came in the hospital, they are 60 kg, and then like the 5 postoperative patient is 70 kg. They have bowel edema. This is a third spacing. They can have that that situation where they have low intravascular volume, but generally they have increased total body water. But that amount of water now is not functional, and it is not participating in fluid physiology.
I'm seeing the hand of Heitem Solanki. Do you want to comment? Because
yes, sorry. I just had one comment, actually two. First one being on the electrolytes. So I've seen most of the time it's a routine for us to just focus on sodium, potassium, and chloride. Whenever we are doing pre-op management or pre-op preparations, we'll find some patients who have not had a meal for quite some time, patients with dysplasia, patients who have maybe ECF. The electrolytes are quite imbalanced. But then we keep on correcting the sodium and potassium. It does not help. It does not get corrected. So I think it's a good practice if we do extended electrolytes where we also take in magnesium. I've noted in a couple of instances where patients with low potassium, low sodium, you keep on correcting, it doesn't get corrected. But when you do a magnesium panel, you'll see that magnesium is low. You correct the magnesium, you'll find out that even your sodium and potassium start coming up. So I think it's a good practice where we do an extended panel for patients, specific patients who have low sodium and potassium. That's one. Second, it's regarding fluid. Now, it might not be quite convenient for patients with third space losses and those with edema and all other problems. So I think it's a good practice also to do a bedside IVC. So we look at the diameter of the IVC to assess if this patient needs to be given fluids or not. You might find that the patient is not getting enough urine output. You might think that, okay, maybe the patient is volume depleted, but at the end of the day, you might overload the patient with fluids if the IVC is full. So it's a good practice also for all of us surgical trainees to know how to do at least a bedside IVC diameter measurement. Thank you. These are the two comments I had.
Yeah, the diameter is measured using the sonography ultrasound. Okay, it's time now for a consultant, Dr. Vihar Kotecha, HPB surgeon from Bugando. You are welcome, and from Catholic University of Health and Allied Science for, I think, 7 minutes.
All right. Thank you very much, Dr. Mugisha. Am I audible?
Very well, loud and clear.
I would just like to congratulate the team of residents to start up this event, this forum, to engage the surgeons who are already in practice, academicians in practice, and let this be the beginning of a good program, something that the residents do require. I understand a lot of academia is going on at university level, but it's nice to share information across the country and get experiences from different facilitators throughout. So please keep this up. Let's keep the momentum. The fire has started. Let's just keep pouring oil onto it. Maybe Dr. Mugisha, myself, and a few other colleagues can coordinate and help the residents keep on doing this on a regular basis. Dr. Minja, I would like to congratulate you to take good time in making this presentation. You have exhausted quite a bit, stretched your arms, even to areas which may have not been so important today, like the ERAS protocol, looking at acid-base imbalances and the like. But you started to nibble into those because you thought they are important and they play an important role when you are dealing with fluid and electrolyte management. Just to make the whole fluid and electrolyte thing easier, I liked when you say that you need to understand how much fluid your patient requires. And most of the times it is something that we overlook. A good way to just decide how much fluid your patient would require is to identify what the needs are, what the patient's weight is, and what condition are we dealing with. Is it a trauma setting? Is it a septic setting? Are we just maintaining in the postoperative period? Or are we giving maintenance fluid like in the ERAS protocol for a patient who is just awaiting to undergo surgery? Remember that when we are planning, so all this depends. And the amount of fluid that you're going to give the patient actually depends on the circumstances. Example, if the patient is septic, the requirements may be slightly different. If the patient is hemorrhaging, the requirements and the type of fluid may be slightly different. And I congratulate Dr. Minja for highlighting those as you are going through the presentation. Areas that I think are important when we are dealing with fluid and electrolyte is you cannot excuse the electrolytes. Sodium, potassium cannot be excused when you are giving someone a fluid. All the fluids that we give have some of these electrolytes in them, except the D5 or D10 or the dextrose-based solution. And so we don't want to do something like overloading a patient. If the patient is euvolemic, the electrolytes are normal. We don't want to do more damage by adding in excessive sodium. And so I would like to really highlight the common practices that we have are infusing normal saline or Ringer's lactate. These are good solutions to use. Absolutely. I have no hard feelings for them. However, the sodium load that you will be offering the body with the sodium chloride, the normal saline, the 0.9%, is a high load. We're adding another 154. And Dr. Minja clearly mentioned the body requirements. I'm not sure if he mentioned, but we, at the end of the day, need to know how much sodium is required per day. It's usually 1 to 2 milli equivalent per kg body weight in 24 hours. And half of that is the requirement for potassium for normal physiological activities. So whenever you are giving these calculations, and Dr. Minja very nicely demonstrated what are the contents of these electrolytes in different type of fluids. So if you come back to me, if you ask me, okay, Dr. Kotecha, what is your number one fluid choice in a patient who is maintaining your in the postoperative period or perioperative period, then I would go down to a solution that is half normal saline. Add a little bit of dextrose and potassium to just continue with the maintenance of all these things. Another thing that we many of times overlook is potassium. Many of times I have found in my ward, patients are given normal saline. Whenever we do a normal electrolyte panel, potassium is low. And you ask the residents or the team who is treating the patient, has your patient been eating? No. Has he been getting fluid? Yes. Then how is the potassium low? And there is no answer. We must understand that the biggest source of these electrolytes in our body is through the mouth. Whatever we eat, whatever we drink are the ones that is giving us these electrolytes. And the fine tuning is occurring at the level of the blood plasma with an orchestrated from the kidney and the other hormones and receptors that we have within in the baroreceptors and the like. So we all know that physiology well, but if you don't feed the body, where is it going to get from? And so that is where the concept comes that please, 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 I would urge you to add a potassium. If you are going to give a normal saline, add a KCl, 20 milliequivalents to 40 milliequivalents, or based on the patient weight as a maintenance. It just enhances recovery. Many of times we complain patients are not recovering paralytic ileus, but there could be electrolyte imbalance that is bringing about this derangement or prolonging the postoperative recovery in the form of a paralytic ileus. So bear in mind that a good solution is, I said, half strength normal saline. I don't know if it is available in many facilities, but if it is not, I think it is a fluid that you should ask the procurement department to get it. Lucky enough, in our hospital at Bugando, we have a small pharmacy that is manufacturing these fluids, and it is usually readily available. So don't undermine the utility of potassium. Correction of fluids, correction of electrolytes. This is another chapter that is very important, and Dr. Minja, you did very well in explaining it. Correction of sodium, correction of potassium, dangers of correcting these electrolytes acutely, especially sodium in patients who have chronic, something we call it chronic severe hyponatremia. And by chronic, this electrolyte imbalance usually means by 48 hours or up to 3 days. If someone has a severe hyponatremia, then you want to take time to correct it. Correct up to 8, correct up to 10. And when you're using that formula, target an 8 to 10 correction. So your expected new sodium from 120 should be around 128. And based on that, you will get the amount difference, and that is what will guide you to the amount of sodium chloride that you will give the patient. Other important point Dr. Hitan mentioned was the use of magnesium. This is a real challenge. Many times we just keep on pushing in potassium, pushing in sodium, but the electrolytes are not changing. Most of the times, this is a situation in patients with enterocutaneous fistulas, enteroatmospheric fistulas, patients with high losses. And so for them, yes, it makes a difference by correcting the magnesium. Magnesium is a cofactor in these enzymes, and that is why when you correct the magnesium, the cofactors begin functioning, and that is when you will be able to correct these electrolytes. By the time there is a hypokalemia, potassium is an intracellular ion. Potassium is an intracellular ion. By the time you are losing potassium, there is severe fluid shifts. Note that in mind. Okay, have a note that in mind. So in order to correct the potassium, you need time as well. You need volume as well. And there are dosings to do this correction. They say if you want to correct more than 20 per hour, you may need to connect the patient on a ECG because of the high concentration. And it has a very narrow window if you compare it to the sodium. The window of potassium is smaller than that of sodium, and the effects of it are immediate on the heart. So you don't want to push the heart into some arrhythmias by overcorrecting with a higher dose, and take time, take 2 hours, 4 hours to correct the potassium. Most of the times it happens in patients who are awaiting surgery, at least those in the emergent setting, patients with peritonitis. That's what I've seen in my practice. So I see residents trying to correct these electrolytes 24 hours, 48 hours, and I usually ask them, and what is going on? Why are the electrolytes not being, is the patient not getting it or so? So a point, again, I would like to reiterate that magnesium could be a problem. Correcting the magnesium could make the difference. Again, the utility of endpoints. And whenever you are giving this fluid, have a targeted endpoint. How are you going to monitor? And weight is one factor that you can use. What was the weight of the patient before your therapy? What is the weight of the patient after therapy? Okay. Most of our hospitals, we don't do measurement of weight, but if we can start using that, it will be a good guide for us, even in the beginning, to decide how much fluid the patient requires. Remember, whenever you are giving fluid, it's the same as giving some medications. It doesn't have, it's not that it has no side effects. Everything that you pump into the body has its own effects. So be aware about that. And another fluid that you would like to use in trauma setting is the Ringer's lactate. Ringer's lactate, we all know, converts the lactate converts to bicarbonate, and it helps with the dealing with acidosis that is occurring in the state of hypoxia, or in a shocked state, if I may say so. And lastly, the utility of an ultrasound. Yes, point of care ultrasound is a good tool. If you can learn how to use it, if you don't know how to use it, you can ask the colleagues within the emergency department, within the ICU, to help you guide, to help you guide the therapy that you want to offer the patient. IVC is a reliable vessel. Look at it. If the diameter is more than 2.5 centimeter, most likely the patient is loaded enough. There could be third spacing, or now what is happening in the patient is the vessels are just too porous. There is too much vasodilation because of whatever reason the patient has. And so you may need to start using some ionotic support. The question that one of the doctors asked is there a possibility when the body is overloaded with fluid, intravascular empty? Yes, Dr. Minja, you answered it very nicely. I'm happy. In patients with liver cirrhosis, it's a hyperdynamic state. There is enough body in the fluid, but it is not retaining into the intravascular space. Most of it is third spacing. And sepsis for us in surgery is number one. For us in surgery, sepsis is number one. Any GI infection, these peritonitis, are going to cause extreme inflammatory reaction. You may all have heard of SIRS, sepsis, septic shock, modes, and the like. So the pathophysiology behind that would be the excessive discharge of the chemokines, cytokines that we are all aware of. And for that matter, at least in sepsis, according to the Surviving Sepsis campaign, you just start bolusing at 30 mils per kg and have target endpoints. How is the urine output? If there is no improvement, you begin with the utility of ionotropes earlier on in the therapy. Do not wait until everything crashes. So you can start with these as early as possible. But when you are dealing with that in sepsis, at least, you must also focus on something called source control. So start your broad spectrum antibiotics MAPEMA as early as possible, as early within 1 hour. And lastly, last but not the least, in patients with enterocutaneous fistulas, those patients who you go in and operate for this reason, and for reasons that they end up with a ileostomy, maybe it's a very proximal stoma, and many of times you may end up doing a double barrel. I think, I mean, some people would do a double barrel, someone would close it, someone would do a loop or whatever, and the stoma outputs are significant. Please realize that you can collect all of that is coming out and refeed it into the distal stoma. This will also help you manage your electrolyte imbalances. It may sound funny, but one of the senior faculty members had told me about this. You may find the losses are in the range of 1 liter, 1.5 liter from the stoma. Collect all of it and refeed it if you can into the distal end. It will help reduce the requirements of the electrolytes that you want to give the patient. And lastly, bicarbonate. Bicarbonate losses we need to measure in the form of ABG for those patients who have high proximal intestinal, let's say, discontinuity. If it's from the duodenum, if it is from the proximal jejunum, then always also have in mind, together with sodium, together with potassium, bicarbonate is another electrolyte that needs to be looked at, and you can correct it by giving sodium bicarbonate if there is a decrease. I don't know if there are any more questions, if it was clear.
It is enough. Thank you very much. Let's hear from Professor Chembe and for 10 minutes. Thank you. You're welcome, Professor. Professor Chembe, if you're hearing us, please, the floor is yours for 10 minutes. If you're talking,
I'm afraid Professor is speaking on mute.
yes, is what
So
I'm
if you
worried.
can unmute yourself, we'll be able to hear you, but you're not audible.
Or you help him to unmute if you can, as an admin.
I actually sent a request for them to unmute.
All right. Yeah.
Let me see if that's going to work. Professor, can you unmute yourself? You can see a pop-up request to unmute. I think there's a message as well. If you can go through the chat.
All right, let me see. Yeah, Rosemary said about, Dr. Rosemary Moshe says about the role of calcium gluconate in hypermagnesemia. For a patient with severe high levels of magnesium, a calcium gluconate can be used to antagonize the toxic effect of high magnesium levels, especially in the heart. It can be used to relieve symptoms while we are correcting the level of magnesium. Also, Dr. Simon Matanjiri says sometimes we experience troubles in eclampsia when you have problems with magnesium or you have problems with fluids and electrolyte trying to complicate your management. Thank you. I do not know if Professor will be able to unmute. I'm worried he might be speaking while still mute. Maybe somebody to give him a call. His remarks are very useful. He has been in the game of surgery for over 10 years now. And therefore he has seen a lot what goes wrong and when does the fluid help us to fix the things that went wrong. Msemo or Dr. Weibo, have you tried to call him? Might have dropped also the call. Yeah, as we are trying to look after Professor Chembe, I would like also to comment that you need to individualize the care that the patient is receiving. There is no one size that fits all the patients. Yes. Do we have Professor Mchembe on board?
Yes. If you can just wait a bit, I think Professor is experiencing internet issues.
Okay.
But I tried to connect with him through a normal call.
Yeah.
I'm pretty sure the audio is not going to be that in a very good quality.
Yeah.
But let's hear from Professor. Yes, Professor, you can just go ahead, please.
Yeah. I was mentioning that. Yes.
Dr. Mukita, Professor is speaking. Please let's listen.
Karibu, Professor. You're welcome.
I would get for the invitation to participate in this discussion on the fluid management, which is a very important topic. As I know, in most of the hospitals, the mostly prescribed medication is IV fluid. For less surgeons, it's even more to know it. I would just speak on three things basically. The fluid we are talking and we need the electrolytes. And to let me just be simplified to use the main three parts of the use of IV fluids. As most of us we drink water, and the water which we usually drink has got electrolytes. There are things which are being dissolved in it automatically, and even the bottled water they also have got some electrolytes. But for our patients, we also have to refer basically to the physiology in our own body of what we have. Our body needs all these electrolytes, needs the water, and it also needs the energy. So basically, the IV fluid we give it for either maintenance, which is the normal requirement of our daily requirements, and also we give it either for replacement. We are replacing for the loss, especially when it is that patient, and also for ongoing loss. So that the major three basically important area which we give the fluid. For the maintenance, it is basically for patients who have been probably nearly already preoperatively and also postoperatively, whereby their blood volume is okay and their volume is in administration. But for research patients, it's for patients who have lost fluid, especially either trauma patients, burn patients, or who have patients who have either during surgery. And for the ongoing loss, whereby we do replace, is for those patients who are losing fluid, which is either water, electrolytes, and also other electrolytes, especially for either patients with intrapercutaneous fistula or patients who have stayed for too long without taking any food. And for the maintenance, we usually give as per body requirements, especially in terms of electrolytes. So, as Dr. Otesha spoke about the use of this fluid, especially when you are talking of sodium or water, all these are dissolved in water, and most of us we do use should be given based on the requirements of an individual. So what is important is to know what is normal requirement for an individual in terms of water and in terms of electrolytes and the energy. Patients, in terms of maintenance, we usually give it for electrolyte, as we know. What is normal for sodium? We know the normal range is probably 136 to 142 millimoles per liter of sodium, which we need it, we have it in our body. So we also have to give it in relation to the amount of sodium needed in the but it is also dissolved. We cannot give all as sodium
Doctor.
In the liters of water. And mostly the presenters say sodium is 154 for the normal saline, which is 0.9%. You have to calculate the amount knowing that if it is 0.9%, it means 0.9 grams in 100 ml. In a 1 liter, you have almost 90 grams. You have to multiply, that is simple mathematics, 0.
Hello, Professor.
Right. You have 9 grams of sodium. And that one, it is the one which will give you the 154 millimoles going to the chemistry formula. How do you get the more moles is equal to amount of the weight, the mass of the gram weight of the substance given, which is now normal saline, which is 9 grams, divided by the molecular weight of sodium. Going back to our chemistry, the molecular weight of sodium that will look at the periodic table. It will give you if you are to divide that, it will give you the results of 154 millimoles per liter. Similarly, even for potassium, the one the presenter said is the 0.5 is actually 1.5 is also equal to percent is also the same. If you have to divide by the molecular weight of potassium, you will get the millimoles which are required. So for the water we need is also the formula is known probably to 50 or 30 to 35 to 50 or to 40 the mils of per kilogram body weight. That is the water we need per day. And we cannot give it as a pure water or distill the water without electrolyte. It has to have electrolyte absorbed in it. So we have to calculate for maintenance that we need probably 2.5 to 3 liters of water, which has to be mixed with the electrolyte. And also the energy which is also needed for patients postoperatively or preoperative for maintenance. So we also need to calculate the energy which is needed, which is also 35 to 50 kilocalories per kilogram for the weight. That also will give you the amount of energy our body needs. Although it might not fulfill for maintenance in terms of energy, because the carbohydrates gives only 4.2 kilocalories per gram of carbohydrates. If you have to calculate, you have to give 3 liters. It means you have given probably 2 liters. That should be of 2% or 5% dextrose. And when you are saying 5%, it means 5 grams in a 100 ml. So in a 1 liter, you have almost 50 grams of carbohydrates. 1 liter of 5% dextrose. And that one will give you probably around the 200 kilocalories. So if we have to give maintenance to it, you have to calculate on that basis so that you provide the required amount in a standard way, rather than pushing. I have seen in many of the words, people are pushing too much sodium, especially they give maybe 2 liters of normal saline, which is almost, you are overworking the patient. Even the normal saline, the 1 liter you can give for maintenance, it has got excess sodium, if you have to compare with the normal we have in our body serum, which is the 136 to 142. So you have excess of sodium. As long as the patient has a normal kidney, that's why he's able to to maintain and be able to survive. But if you have a patient with renal failure, then you will overload that patient because the kidney will not be able to expel the excess sodium. And you may end up with edema of the root postoperatively, which can you especially even for risk of infection. So in that case, for this section as well is also the fluid, which is basically the normal saline or ring arrested, which will replace so that we are able to fulfill the extracellular compartment adequately. So important is to consider those three areas. I may not be able, you have to check especially for this replacement for patients who are ongoing loss. So you have to calculate and check the laboratory testing the electrolytes which are been either being lost. And you have to recalculate and see how much the electrolyte you should supply. I don't know whether I have.
Fulcrum, doctor.
That is a very important topic. It will be shared among our colleagues, among doctors. I know there are so many patients who have lost life because of the issue of IV fluid, because of not considering what is required for this particular patient. Thank you very much, Tim. If there are anything to ask, I don't know how I can cover that.
Sure. Thank you so much, Professor. I think Dr. Mugisha, you hear what Professor spoke, and if there is anything to add or ask, please. Let's see if Professor can hear you.
Yeah, thank you very much. I think we have come to the end of the webinar by Professor's remarks. I am open for further discussions in the near future. If you didn't have a very clear understanding, we are still reachable. You can reach us. Semo can share Professor's number, the Harry's number, and myself number to try to understand your localities and the challenges that you're having in regard of fluid therapy. Today, we have met and discussed about two major subjects in surgery, basic science, basic surgery component, which is fluid and electrolytes. As the book describes it, it is very important that we individualize these interventions that we have into each patient's lives. Patient X might not have the similar requirement as patient Z. So it is important you look at them judiciously and you address each and every bit wisely and proficiently. I hope you will improve and you will integrate this particular talk into your daily practices. Knowledge alone is not enough. It is not useful unless it is put into practice. Alam Sik, good night, and see you next time. Thank you very much.
Thank you. Thank you so much, Professor. I think it's end of the meeting.
Yeah, thank you very much.
All right. Maybe just before we all leave, a very quick update. This meeting will be shared on our website, the TSA website, specifically in the resident chapter. So for those who have registered on the system, they will receive actually an email for the meeting, what have been spoken, and you'll be able to hear again this the whole conversation from start to the end, which will be shared through the TSA website or TSA system. So I encourage everyone, for those who did not actually register, not for the event, but those who did not register to the TSA database or TSA system, please just register yourself and you'll receive all this information and updates as they've been posted. So thank you so much and have a good one. Bye-bye for now. Yes, baby.